So once again, we continue with our project looking at anatomy with respect to movement as a central point of our network of meaning or our semantic network. And here we're looking at knee flexion, and just a quick general reminder that when we're speaking about a particular motion with respect to osteopathic hands-on work or osteopathic manual therapy, what we're talking about is finding the area with the preference of this motion. So this would be your motion diagnosis. The knee would prefer flexion as opposed to extension. So as is consistent, our general objectives or our objectives is a specific discussion of what knee flexion is with respect to the motion itself, as well as the planes and the axes, a general discussion of the muscles that generate the motion, the neurovascular bundle, as well as areas for consideration with respect to assessment and treatment should issues with knee flexion be suspected, reported, or identified. Now, our quick review of planes, as we do consistently, the sagittal plane is 50% cut of the body left to right, horizontal or transverse plane is 50% cut of the body top to bottom, and the frontal or coronal plane is 50% cut of the body back to front. With your planes being perpendicular to, your axes being perpendicular to planes, the sagittal plane has a horizontal or transverse axis, the horizontal or transverse plane has a vertical axis, and the frontal or coronal plane has an anterior to posterior or posterior to anterior axis. Now, with respect to knee flexion, the best description of knee flexion is essentially approximation of the posterior aspect of the tibia and the fibula, or the leg, or the lower limb below the knee, with the posterior aspect of the femur, right? So it's essentially the knee closing. So if we take my elbow as the analog, so we've got a relative straight elbow, or in this case, the analog of a straight knee, this would be considered extended. And we consider this the posterior aspect of the tibia and the fibula, and this the posterior aspect of the femur. This is knee flexion. It is, you can call it closing of the joint, but depending on your perspective, you could say that the joint is closing, or the joint surfaces are more congruent or more closed when the knee's in extension. Probably not going to hear that much, but you could make that argument. So the most appropriate or most consistent description of knee flexion is approximation of the posterior leg with the posterior thigh. Now, in the anatomical position with the legs directly under the torso and the toes pointing forwards, this is going to occur in the sagittal plane about a horizontal or transverse axis. However, if you point the knee out to the side, right, so you take the entire thigh such that the knee is pointing out to the side. So we pretend that this is the knee and I'm upside down, and the knee's pointing this way, then flexion and extension no longer occur in the sagittal plane with respect to the cardinal planes. They're occurring in the coronal plane. If you're able to generate a situation where you create general medial rotation, then knee flexion and knee extension, in this case knee flexion, would be occurring in the transverse or horizontal plane. So the motion of knee flexion can occur in any of the cardinal planes depending on the orientation of the thigh with respect to the torso. But in most discussions, knee flexion is going to be considered to occur in the sagittal plane. That said, the motion description of approximation of the posterior leg with the posterior thigh is probably the most consistent regardless of plane or regardless of axis. With respect to the muscles that are going to generate knee flexion, we're generally looking at the hamstring group. So you're looking at the long head of biceps femoris coming from the ischium to the tibia. You're looking at the short head coming from the femur to the tibia. You are looking at the semitendinosus and semimembranosus. I believe semitendinosus being part of the pes anserine group. And then the other two muscles in the pes anserine group, which are assistive in knee flexion, but not necessarily the prime drivers, are going to be sartorius and gracilis. So just to reiterate, long and short head of biceps femoris, semimembranosus, semitendinosus, gracilis, and sartorius. So that's the soft tissues, which means you're basically going to have to look through the posterior, anterior, and medial compartments of the thigh with respect to the soft tissues. So you essentially have to look the whole way around the leg with respect to the muscles that would generate a preference, so generate the motion of knee flexion or lead to a preference for knee flexion if that's your diagnosis or your observation. With respect to the neurovascular bundle, first we'll just kind of try to get to gracilis and sartorius. So sartorius, I believe, is the femoral nerve, and gracilis is the obturator nerve. So you're looking at the lumbar plexus there, and you're looking at the anterior and medial compartments of the thigh. Neurologically speaking, for those two muscles, for the hamstring group, you're looking at the sciatic nerve. So at that point, you are looking at some portion of the lumbar column as far as the exit of the nerve from the vertebral column. You're looking through the pelvic region, really the posterior aspect of the pelvis. So you're kind of looking at the posterior aspect of the greater trochanter, and then you're going to look down the posterior aspect of the thigh to follow the sciatic nerve. As far as blood supply is concerned, you are looking more or less from the inguinal region to the anterior aspect of the thigh, the medial aspect of the thigh, for the femoral artery, and then branches thereof, which will supply gracilis, or the obturator artery is going to, I believe, supply gracilis, at least to some degree. But you're looking anterior compartment of the thigh, medial compartment of the thigh, and then the profunda femoris, or perforating branches, coming through for the hamstring group. You're still looking at the anterior and medial compartment of the thigh, but then you're also looking at the posterior compartment of the thigh as far as the vascular bundle is concerned, or the vascular portions here. So again, this helps us make the case that if you're considering the neurovascular bundle, then you're going to have to go to the lumbar column, the anterior, probably the abdomen, maybe to some degree, but really the inguinal region. You're looking at the anterior compartment of the thigh, the medial compartment of the thigh, the posterior compartment of the thigh. So you're looking at all these areas just for knee flexion, which helps us make the case that if you pay attention to motion dysfunctions, either in the form of gross motion dysfunction or in the form of alterations in tone with yield to pressure in soft tissue testing, and you behave accurate to your motion findings, and there is a relationship between altered motion and alteration in function of the neurovasculature, then finding the motion dysfunction is the most accurate thing you can do, instead of just going up and down the whole line expecting to find something. Check the whole body, find motion dysfunction, deal with motion dysfunction, and to whatever degree it is impacting neurovascular function, then they should change in kind when you deal with the motion dysfunction, instead of just chasing the whole thing, because this is a very large area to consider just for knee flexion. Now, if you're considering treating any motion dysfunction you find, you're accurate. If you're considering chasing the neurovascular bundle, you're probably not going to accurately identify the neurovascular structures. You're probably going to be in the wrong region, and you're probably going to miss something. So just as our general reiteration for areas of consideration for assessment and treatment, the lumbar column, neurovascular bundle. Now, I said posterior, it says here just posterior soft tissue of the thigh, but realistically, you're going to have to think about the inguinal region, the anterior thigh, the medial thigh, the whole deal. Anytime you're dealing with the lumbar column, as far as contraindications or red flags, any pressure on the abdomen that doesn't immediately create pain, and then you let go, and then that creates pain, that's rebound tenderness. That is a visceral pathology. Doesn't matter which one. You don't need to know. You just need to know that it needs to go. Any in those regions, known fractures or tears, you don't treat them, because you can make them worse. Suspected fractures or tears, known fractures or tears, you don't treat the known fracture or the known tear. You can treat the patient. You can help them in some way, but you don't treat those areas, because you will make it worse. Suspected fractures, suspected tears, send them out for further investigation. If no tear and no fracture are identified, and the patient comes back, then you can increase your confidence with which you're willing to treat in the region. You're still very cautious, but you need to know that there is no fracture and there is no tear. So that's why you send that out.